My name is Xavier Caro, and I'm a rheumatologist and clinical immunologist here in Northridge, California. I'm also the director of the Southern California Fibromyalgia Research and Treatment Center. These videos are meant for my patients to better educate them about what they're going through here at the center, how we evaluate their fibromyalgia, and go about treating it. If you're a visitor, by all means, you're welcome. You may want to look back on our other videos, though, to better understand what I'm going to say here. In this video, I want to spend a few minutes talking about associated symptoms of fibromyalgia that are not necessarily as painful as the ones that we talked about in our last video. More specifically, I'd like to talk a little bit about the patient's complaints of cognitive dysfunction and chronic fatigue. These are two areas that are not as well understood as the painful problem of fibromyalgia. Recall that as a rheumatologist, one of my major charges is to get people out of musculoskeletal pain. It's sort of what rheumatologists do, if you know what I mean. We're not really necessarily sensitized or trained to go after fatigue or to go after cognitive problems. The reason for that, not entirely self-evident, but if you're going to deal with fibromyalgia patients, you're going to have to school yourself as a practitioner about these two very troubling symptoms. With regards to cognition, we commonly hear our patients tell us that they do not function as well as they believe they should. Typically, they may have been an A or a B student and now are performing much below that in their everyday lives and particularly at work. I recall one patient whose IQ testing that we did on him, I told him, thinking what a great compliment this would be, that he had 110 IQ, and he told me, I was a Fulbright scholar. That's pretty bad for me. In any case, the difficulty with cognition is not so easily understood or treated, and I cannot tell you that we understand it much better than many others. But we do know the following. It is something that tends to progress as the patient gets sicker with fibromyalgia, and yes, fibromyalgia can worsen, but it also can get lessened when the patient's fibromyalgia backs off. Almost all rheumatic diseases wax and wane. And the typical fibromyalgia patients will tell you, I'm having a particularly bad day, or I'm much worse now than I was a year ago. We can monitor this with relatively minor testing, and we are convinced that patients who undergo successful treatment notice that their cognitive function improves. I tell them, we can get you back to where you were before your fibromyalgia started, but we can't necessarily make you smarter than you were. In any case, typically we ask patients to do or to carry out certain maneuvers here which will allow us to monitor them. Because attention testing is so simple and reproducible, and there's no retest improvement due to practice, we use tests of attention here fairly frequently. One of our favorite instruments is called the TOVA test, or TOVA, tests of variables of attention. And we use both an auditory and a visual stimulant to produce a TOVA score for attention. Not necessarily the overall score that you would like, the perfect score you would like, but not an unreasonable way to follow patients' cognitive function. Yes, undoubtedly you're thinking to yourself, well, wait a minute, I have musical abilities that are not what they should have been. I have mathematical abilities which are not what they should have been, and so on and so forth. We have tests for those as well, but for routine and everyday testing, we find that on the average, the patients with the TOVA testing TOVA testing is sufficient for our needs. It's a very simple computer-based test in which a stimulus is produced, and you're asked to react with a push button to the stimulus in one way, and then when the stimulus reacts in a different way, you are asked to not react or inhibit your tendency to react. Similarly, we have the same test, but it uses sounds, a high tone and a low tone. You're asked to react to one and not to the other, and then vice versa. This kind of testing sounds rather rudimentary, and it probably is, but it's excellent for following patients, and we can show that patients tend to improve in their cognitive function over time. Now, let's talk about the fatigue factor. It's very common for patients to complain that they have significant fatigue associated with their fibromyalgia. Fatigue is one of the most difficult subjects for patients and practitioners to understand, and that's because it's so incredibly complex. We know that there is a fatigue that's often associated with inflammation. This is well established and goes back decades, if not hundreds of years. But in any case, relieving the inflammation in patients with fibromyalgia is often significantly associated with a profound improvement in fatigue. Secondly, fibromyalgia patients tend not to sleep very well. The reasons for this are numerous. In no particular order, they complain that they are depressed, as most patients will become after only 6 weeks of chronic pain. Next, they may complain they're so painful that when they toss and turn in bed, they in fact wake themselves up or are awakened by their pain. Perhaps a variant of this is so-called restless leg syndrome, which we see fairly frequently in fibromyalgia patients. We believe that to be a component of the neuropathic disorder affecting the legs. Now, all of these things then cause them to be fatigued. And we find routinely that patients who are successfully treated for their fibromyalgia find that their fatigue factor abates. Now, it may or may not abate to the point where they feel completely relieved, because it's one of the toughest of all the problems of fibromyalgia to treat. Nevertheless, there will be improvement in that as well. And if fatigue is a particular issue, we may schedule some visits just to address that particular problem as opposed to the pain or cognitive disorders. So, you see, treating a patient with fibromyalgia requires a multifaceted approach, and we may need to measure, depending on your complaints, we may need to measure components of the immune system, your cognitive function. We may need to talk to you about fatigue and how it's bothering you, and of course we'll want to measure pain serially. As we treat you, we would look for all of these to improve. Any that hang back need to be addressed. Occasionally, there's a more important issue underlying one of them than we suspected. We'll try to keep our eyes open to that, and we would ask your cooperation in telling us if one area is not improving as we expect. Now, before I close this segment, I want to add one other thing. It is important that you understand that the neuropathic injury, which is so painful to you, is not necessarily going to go away the moment inflammation is shut off. And secondly, inflammation is not so easily shut off as it sounds. Okay, so let's talk about neuropathic pain being shut off. Think about it, if you like, think about it as a target. Remember, a target has a bullseye with surrounding rings. The bullseye then will be tissue, let's call it nerve tissue for the purposes of this discussion, which is dead. This nerve tissue has been injured beyond repair. The first ring around the bullseye represents tissue which is in danger. It is at risk of dying. Next is a ring of tissue which surrounds the danger tissue, surrounds it, and is healthy. So you have healthy tissue around that tissue which is in danger, around that tissue which is too far gone. It's the center tissue, the tissue which is in danger, which we believe generates the greatest amount of pain. And it will flux back and forth depending on numerous factors. And it's the tissue we're trying to save when you go about your treatment. Now, we typically follow patients as they go through their symptoms. And here's roughly the three grades of symptoms of pain we believe comes from that center ring of tissue. Patients come in, let's say on their first visit, and they say to me, you know, as I sit here, Dr. Caro, I am so uncomfortable. I ache all over. I want to weep with the amount of pain that I have. Please, Dr. Caro, do not touch me. Then, after treatment, the patient says, you know what, Dr. Caro, I'm uncomfortable, but if I don't move or no one touches me, I'm okay. And last is the patient who says, you know, Dr. Caro, do you remember when you used to squeeze those areas on my body and I would jump? You can do that now. I'm okay, maybe except for my legs, which are still a little tender. That's the way we follow our patients. So you'll be surprised when that happens to you. But we ask that you look for it so that you can tell us, in fact, whether or not we're succeeding. So you can see that offering patients relief from their pain is not necessarily an overnight phenomena. There will be stages, that is, you'll improve in stages, and we ask that you keep us informed about that. If you're not moving toward the better, we'd like to know it, that's for sure. Okay, last, I want to talk to you about inflammation in general. Inflammation is a very difficult component of the immune system to shut down. And the reason it's difficult, in part, is because shutting it down is, to a certain extent, dangerous. Remember that the immune system uses inflammation to protect you against invading organisms. Let's say, for example, you have an infection that comes from a cut. The surrounding redness and the pus and the pain, that's all inflammation, you see. Now, if you didn't have that, that infection would spread. So you need inflammation. If you have surgery and have no infection, it still heals using inflammation. So you can see that shutting down inflammation is difficult, and we walk a fine line between overdoing it and underdoing it. We like to think that we've developed some expertise in this endeavor, but it may require one medication or more than one medication. Rheumatologists are very accustomed to shutting down inflammation, and I don't believe that rheumatologists who are sensitive to this would have a hard time shutting down inflammation. But many, many rheumatologists, general physicians, and other practitioners do not recognize the inflammation that's going on in fibromyalgia patients. So I will be spending a goodly amount of time looking for signs of inflammation, teaching you about what I will be looking for so you can give me that information, and then setting out to shut it down delicately, carefully, in conjunction with our other treatments. And I'll talk to you about that and how we orchestrate them in our next video. Thank you for listening.